Watching the full view here on SABC News Channel, the second hour here in Studio 9. Thank you so much for joining us. I'm Tsepiso Makwetla.
And I'm Aldrin Simpier. The South African Medical Association is addressing the media in Pretoria. Health Minister Zweli Mkhize is leading the presentation. Let's go live.
Stay on quarantine. At the same time, we had also had a story of one South African who had been found to have been positive in South Korea. It has since been rigorously investigated, and we now have confirmation that in fact that was fake news. The gentleman reported a positive test which he hadn't had. So when he was actually asked to divulge the institution that had tested him, he could not do so, and then he ultimately confessed that it was not true. So that means that outside South Africa, at that time we only had 2 people. Even those who had been in Wuhan, and we subsequently got them back, and those who had come from China, we never actually had one person infected from China. Those who came from Wuhan were actually put up in Limpopo. The first tests that were done on them came back all negative last 3 days ago. So the real issue now is that coronavirus arrived in South Africa 14 days ago. We panicked with one patient. I can tell you that we got even more surprised to see the rapid spread of the rapid increase, because 2 days later we were actually at 3, and then it started moving in that direction. As up to last night, at 8 o'clock, when we do a cutoff of the reconciliation for the day before we announced today, then of course we had 150. And we are quite certain that by tomorrow we would have gone much higher, probably just beyond 200. So the reality for us is that we need to be working together to deal with this issue. And as you will be aware as well, the President has gone all out to call for a lot of stringent measures, declaring the state of national disaster, and also excuse me, and also got a lot of stakeholders, leaders, to come together and unite in an effort to fight this virus. The National Command Council has been formed of the President and ministers, and we've been out there. President has met with various political leaders, and the different opposition parties have come unanimously to say this is not time for politics, this is time to fight together, which we appreciate. We appreciate the initiative of the President. Today we met the leaders of the largest of the church groups in South Africa, mosques and synagogues, chief rabbi and the top imams and bishops and archbishops. And all of them came out saying they really are going to do everything in their power to limit the spread of the infection by reducing, in fact, cancelling most of their huge gatherings, and then of course reducing the numbers of people who attend per service. I like the approach where they say, turn your home into a church, turn your home into a mosque, turn your home into a synagogue. Don't stop the prayer, but everyone must pray at home. So that the numbers that have to congregate together were very, very limited. In that process, they also went up to say to those who believed that they would need to come together to pray, because that's what would actually help them. But they said that we need to combine the two. That whilst you pray, but you have to take the necessary precautions of good hygiene, social distance, and so on. And I loved one bishop said, there was someone who was praying and said to them, no COVID infection shall prosper. Saying to the one gentleman, and then of course the bishop was saying they need to be informed, and he quoted the verse that don't put your God to test. The reality is that they have enough biblical basis to motivate for supporting the call by the president. I therefore want to say that from where we sit, we've met taxi organizations, we've met various other leaders, there'll be other traditional leaders and so on, traditional healers who will be met as we move on, individually and collectively. All of those have been very supportive, and therefore the issue is how can we make sure everybody spreads the message. When we are here meeting with SAMA, we believe we're actually meeting the real foot soldiers, the fighters in the forefront, who are the ones who will actually help us to locate the presence, the trend, the manifestation, and different aspects of this infection. So we have seen that the various provinces are slowly showing up. At the moment, Gauteng is the one that's got the largest at 75. We have KwaZulu-Natal 23, Limpopo 1, Mpumalanga 5, Western Cape 46, and of course these numbers are going to increase because tomorrow we will be reporting about Free State as well. The numbers are actually on the rise. But we've also seen the behavior of the infection. Today, Italy is 35,000 people infected, and the mortality rate is almost as high as China, who are at 80,000 of patients. But China, at 80,000, they've actually almost tapered off, and the numbers have not been showing a lot of increase. They've seen a lot of recoveries, and at this point, over 60,000 people have recovered. And it's important for us to look, in fact, it's much more than that. I think it's getting close to above 60,000. But it's important for us to say, we are not going to be different as South Africans. We are going to have to face up to a number of lessons from various countries, but at the same time we are unique. We should actually understand that we can behave in a way that can change the course of this infection. So with both of those, it means whilst we have to be alert and learn from what the others have done, we also need to make sure that we make our own history as South Africa. So with that, we have had a discussion. 3 days ago, we met a number of clinicians, pulmonologists, intensive care specialists, infectious disease specialists, virologists, epidemiologists, a whole group of professionals who are all involved in this whole fight. And went through this whole discussion. The idea which we thought was important was to be able to discuss how do we ensure that amongst ourselves we coordinate our effort. How do we make sure that those who are involved in the clinical management of all the cases are able to coordinate, are able to talk together, and we are able to almost standardize certain approaches in the management so that we are able to say, anyone who needs assistance, this is the kind of approach that we are utilizing. And it's important for us to be able to do that because we are not only just treating individual patients, but the public outside is also watching how we're managing. And people mustn't kind of feel that this is what was done, that was done on someone else. Therefore, they must then not start having a sense that someone knows what they're doing, the others don't. And this is actually a bigger problem in the days of fake news. So we had quite an interesting discussion, and therefore we even agreed at that point that we are going to be, we're in the process now of forming a ministerial advisory committee on the issue of the outbreak, which will coordinate a lot of efforts. And we were then saying that on the one side we need to see a clinicians society that will be discussing various approaches and looking at the various lessons from all over the world on how to deal with this virus, as it were. Lots of speculation out there, and people have spoken about antiviral treatment, interferon, chloroquine, etc. But we are aware that there's a whole lot of trials that are going on at the same time, including the issues of vaccine, which we need to upfront say that at the moment there's no vaccine available, and we make this just not so much for the doctors because they all know this, but because in the public arena, now and again you get someone who stands up and say, well, there's a vaccine somewhere, why don't you get the vaccine? The Professor Helen Rees is part of the WHO team that is actually leading South African effort in the creation of that of the vaccines. And so in the next 18 months, we expect something should come through by way of the vaccine, but there will be participation of South Africa by around June when this trial actually takes off. So we are asking that on the clinician side, there should be some discussion which allows us to be able to say these are kind of standardized protocols which we can all utilize. Then, of course, there's a space for debate. There are lots of issues for debate, very interesting issues for debate, as it were. But then the second group that we thought we need to focus on would be the group that deals with the pathologists, virologists, and those and laboratories, so that there's a coordination across that sector. Today, I had the opportunity to talk to CEOs of most of the top private laboratories. On Saturday, I also had a similar discussion where we're talking about how to make sure that we treat our testing capabilities as just one service, one institution, where everybody will test and they standardize their approach, they talk to one another. We even said they must have their own chat group so that if there's anything you are not sure, talk to the others. At this point, it's important that they coordinate, they are standardize their approach, that they also talk to each other so that when there are queries on the results that they are getting and the issues around approaching what technology to use and so on, there's quite a lot of stuff that comes up which is interesting, as it were, particularly when they are interpretation of results. We've had an instance where you've got someone who comes up positive, and then a few days, a day after that, done by one private lab, positive, and say, okay, let's validate in the public NHLS laboratories. It comes out negative. A whole debate that has come up. And in fact, ultimately the consensus was that judging from the way that the disease is manifesting itself, it needs to be accepted that they caught this particular patient at the tail end of a viral shedding period, and therefore now when they came in later, the patient was already turning negative. This is an interesting angle because if you look around, it's not clear what's happening to the younger people, but it looks like most of the younger people may well be having the virus and might be shedding the virus for shorter periods, but of course that's subject for research. So you will have your own experience where you are, where you can guide us in terms of what you are finding. So that would be the one group that is looking at this issue. Then of course the other, we said that you need the other group that will actually look at dealing with mitigation issues, prevention issues, the epidemiological trends, and various observations that are guiding us in terms of the development of this entire problem of the outbreak. We have also asked that the provincial leadership need to break down and organize themselves according to districts where public-private must be able to relate, look at what capacity is there, how many practitioners are there, public-private, how many facilities are there, how many beds are there, what level of care is possible in a district, so that it is not difficult to coordinate. We've now come together to work with the private hospitals, and we have said at a certain point when we need extra beds, and the hospital was the public sector initially identified a few hospitals. As soon as we saw that the threat was rising, we've actually said increase the beds. There must now be decentralized beds which are created on a city-to-city or town-to-town basis, so that we must have more space to be able to absorb a number of the people. At the same time, we're looking at possibilities of assisting in quarantines. It's easy right now when we're dealing with quarantine, particularly when the people have been traveling to Europe and all over. They're actually middle class who have got well-demarcated areas. It's easy to control movement of people into the area. Some of the areas, the level of congestion will not allow, the numbers of people, they will not allow easy isolation or easy quarantine. So it means, therefore, we need to actually start providing situations where people can actually be moved off their normal settlements into quarantine areas. All of these are things that we are looking at, as it were. On the other hand, we've also started negotiating with various hotels, so that around the airports, international airports, we are able to provide hotels to be able to draw in people who we believe need to be quarantined. Instead of allowing them into the country, we quarantine them around the hotels, and therefore we need to work out protocols around those issues. So generally, in terms of the broad thrust of managing this infection, I think we're more or less moving together. We're looking at how to increase the testing capabilities so that we can test as many people as possible. We've been talking about it, that at this point we've just probably gone about 1,200 tests, and this 150 comes from that number, but we now need to start being ready to test a couple of thousands per day. Both those who are symptomatic, as the guidelines say, but then we believe that now this is time to actually have targeted surveillance, where we go to areas where we think there might be risks and be able to assist there. And secondly, we need to also be able to increase capability to have what we call drive-by testing and mobile testing capacity, as it were. All of these issues are important as we deal with this. We've also asked that our team must now work very closely on looking at recoveries. In this case, for example, the one person that I said turned negative is the vet student who actually created a huge excitement in the university community. That has been the interpretation. But the one in Pietermaritzburg was the second patient to be identified, was asymptomatic when they took her to hospital. And at the end of the day, has had to be discharged, but also had already tested negative. So we now want to start recording those recoveries, as it were. So far, we don't have any record of any death, which is very, very important. Now, the real challenges are how do we manage a lot of issues. When we talk about communities out there, to send information and get education to community to be educated is very, very important. So we are going to need to work together, that every general practitioner, every doctor, every private practice should actually be part of a network where we are able to share leaflets, share information, so that we are able to actually send this information as widely as possible to the community. There are challenges of supplies, the shortage of barrier protection clothes, gloves, masks, and so on. There is a risk of price hikes, but there's also the whole world is looking for the same stuff that we need. And for that reason, we need to then talk about how do we use judiciously those kinds of equipment and protective gear that we need, when in fact the whole world is going to be in need. So we need to then start talking about at which levels in the isolation ward is clear. You need protective gear and all the whole kit, and everyone is clear about that. But at which point are we starting to look at on the public facilities in the private sector, that when you deal with a large number of patients, you actually have to get your staff to wear masks and so on. And we need to be talking about all of those issues. Or should we just confine it to the area where people are having only respiratory symptoms and so on? These are the things that we have now to start working on as we try to make the gowns and sort of make the masks and gloves available to the different levels. It's important as well. There are high pressure areas where there's lots of overcrowding and lots of patients, and all of this is something that we, at the moment, is easy to identify imported cases. But once you've got internal transmission, you can never know that this one is not, particularly as we move into the area, to the time of winter when the flus and colds are going to be increased. Now, the real issue has been that the first patient who was diagnosed by a doctor was pretty wise. immediately she was able to say to the patient, "You go into quarantine, I'm taking a test on you." And look at the symptoms were not very bad, but that's what the doctor said. And as soon as the results came back, she went to quarantine herself. Now, there are going to be many of us who are going to then ask the question, how do we avoid ourselves being exposed so that you don't have to be quarantining yourself, or that, in fact, the patient may not immediately display the symptoms, and once it's gone, then you find that you could have been exposed. We're talking today with the MEC of Western Cape. She's completely well and very wise in her decision. There was a diplomatic corps that had convened, and therefore there was a whole discussion. And in the process, one of the consul generals actually was found to have been positive, and then of course it prejudiced everyone else. Now she has to go on quarantine. It's easy when you deal with it in an environment where you can identify a possible source of the infection. Imagine someone who then comes from Langa, takes a taxi, and gets from there into a train and takes a long distance from Cape Town all the way to Johannesburg, and then goes further to Limpopo and back. Now you want to ask them if they know who their contacts were. Now the challenge is that even if she can tell you where she was, she's really, or he's really not able to know who was in the taxi, because half the time you don't know who's sitting next to you in a taxi. So those are the issues that we must now be conscious about. So when the steps we took to say, let's actually start putting the restrictions, is to actually reduce the possibility or the rate at which COVID-19 virus will start spreading to affect people in the areas where we know are most vulnerable. And that's really what the issue is about. We're trying to flatten the curve, we're trying to delay the onset of the infection, but we are then saying we need to discuss the issues that relate to you. We would like to get your suggestions. What's the best way of dealing with this situation? Somebody will come to see the doctor, and then, do you remember every day who was there, how many people were there? It's very difficult. There's a typical example. We've just had, a few days ago, a doctor came from, I'll tell you about these two doctors. The first one came from, he had gone abroad, and then we're discussing this issue that most of our people are now getting infection from, such countries as Italy and so on. And the doctors were sitting there, and they said, "Oh, Dr. So you came from one of those countries." And then they agreed that he's going to go into quarantine. He quarantined himself, and then decided, "You know what, I'm going to do a specimen." He did it and then came back positive. And that was quite nice, because everyone took an immediate precaution, kind of. We now need to check if there was anyone who could have been affected. The other one was less fortunate, because he came back well, asymptomatic, and then a little bit of upper respiratory tract infection, and all of a sudden he went around, he operated, he met with people, and so on and so on. And all the way he went up to see his GP to say, "This thing is irritating me, can you just sort it out?" He said, "Okay, go test." And all of this was just open. All of a sudden now it was positive, and then we now have to go back to the hospital and say, "Okay, over these past so many days, you start finding a larger number of people who must now be pulled together." So these things are going to happen all to us every day, and you will not see it then. You will see it after it had happened. And those are the things that we must discuss. What are your suggestions, as it were? As we increase the testing, we hope that we should be able to get to a point where we target certain areas where we know, for example, that with the flus that are coming, there are people who are going to be, because of the time of the year, are going to be coming up more and more with this. But how many of them do we know already could have been affected? Because of this phenomenon I was describing about people moving from taxi to car to train and so on. So we need to actually target certain areas and do some kind of surveillance. There's a big debate that came up in that meeting of the clinicians as well between us and NICD. Others saying, no, the guidelines are you test the symptomatic. And we say, well, symptomatic, yes, but if you got me out there in the village, half the time I'll have the cough and a bit of a flu. I won't rush to go see a doctor, especially if I've got so many other worries to worry about, even transport fare and all of that. That becomes one of the challenges. Then it becomes an issue of someone will be infective and they don't know about it because they don't feel it's a very serious issue. We all know 80% of the people have got a mild or moderate disease, and most of them won't even get to see a doctor or won't even get to be admitted because of the mildness of the symptoms. So how do you deal with that? So we might need to do those kinds of spot checks, as it were, a surveillance kind of mechanism. So these are some of the things that we now need to be talking about amongst ourselves. So really, as we are sitting here, we are talking about what are your experiences, what are your suggestions. One of the things that's become a very interesting debate is the fact that if we went 4 or 5 weeks ago, the COVID-19 test was being done by public sector. And therefore, if any private sector had it, wanted to do it, would just simply screen for the other viruses and send the specimen to the public sector. Right now, private laboratories are doing lots of tests. In fact, 97% at least of the patients who have been diagnosed have actually come from private sector. I don't remember anyone that really came from a public hospital or a clinic. So the bulk of them have come from there. But there's a cost to it. So how do you deal with the cost? Because now people have come and said, okay, we're told that we need to try and get ourselves to test, but the cost of it might be inhibitive. So that means now we have to actually open up the testing a lot more wider than what we might be doing at the moment. So then it becomes a bit of a challenge, because if you are better, your symptoms are gone. Now, what's the problem? You want to be, you want to spend another 1,200 or 1,400 rand to check whether, but you're feeling better now, So a number of people may not go back to test because it's costly. That's why they got the first test. They were worried that time. Now they're no longer worried. So that's an issue that we have to look at. So what we have now been saying is that we need to ensure that there's a proper coordination, and we need to get assistance from the private doctors. One, when you test people, can you take as much details as possible at the first time so that we don't have a problem to follow up the patients? The tracking and tracing becomes a problem. In this yesterday's batch, there's a lot of instances where we say not enough information, not enough information, not enough information. It makes it difficult to go back. Secondly, we have said that sometimes when we get the test and we are going through validation and we are going through the processes, then the doctors get informed, and then the patient and the relatives, they go on a whole Twitter campaign, and before we know it, people are saying, oh yeah, but the a minister doesn't announce that there's a patient in such and such a place. That means they are actually not telling us the truth. Fake news becomes a big issue there. Whereas if we'd been able to coordinate this information, that would become it would be less of a problem. So what we are now asking for support on, we're going to get an NGO that's going to help us to do the mop-up. So after 14 days, you get the patients that are well and don't want to go back to the doctor, but we must then go and knock on their doors and say, you have 14 days, we want to take the last specimen, so that someone doesn't have to have the option of whether they go to the doctor or not and pay 1,200 because they don't want to pay that they are well anyway. So we want to be doing that. Then we also need to make sure that there's a strong coordination from NICD, National Department of Health, and provinces, broken down right up to district level. It's important because the real war right now, where we're having a weak element and we're trying to catch up with it, is tracing of contacts. At this point, they have recruited very close to 2,000 tracers, and therefore are coordinating the system so that we can ultimately be able to do this quickly. And we're trying to look at various mechanisms of how to improve the contact tracing. That is the angle that's going to help us. So high level of suspicion to the frontline doctors and nurses in the clinics and hospitals. At the same time, also the efficiency with which we're doing contact tracing. If we can lock those two and increase the numbers of tests that we do, we will then be able to actually match the spread, the rate at which the the infection is moving. That is where we need to be. So whilst there are restrictions now, I think this week we won't be able to see much of a difference, but we must start seeing a bit of an impact, and the impact we will only get if we're all working together to try and say we do the same thing in the same way to everyone wherever we are. So that's why we came to talk to the doctors here to say, can SAMA partner with the department? Can SAMA work with us? Because the bulk of the people who are going to see the presentation of the infection are members of SAMA in private, are members of SAMA in the public sector. We need to say, what are your challenges, so that we must meet each other halfway to find a way to resolve those challenges, to improve your capacity to detect the infection, to prevent the infection from going from the patient to you, and to actually help to prevent the infection from going one patient to the next person. That is the fight that we must wage, and it's us at this level as professionals who must be very strong in this fight.